Okay, so maybe this will be more for surgeons and gynecologists.
Yeah.
Thank you.
So how many people are doing ultrasound for the breast in this room? Everybody? And the others will have a look at it and can maybe learn it or think about it for learning. The meaning and application of BIRADS classification is my topic today. I would like to give you a small talk. Excuse me. So, what is the BIRADS data reporting system for? The BIRADS is very important for communications between radiologists and other types of medical staff, so surgeons or gynecologists. We all should know what we are talking about, because BIRADS is thought to be an international code. Each report of breast imaging has to have a BIRADS classifications, because then everybody knows what is going on in this breast. Even when you do an MRI or even when you do a mammography, there should be a BIRADS classification. And when you have a BIRADS classification 4 and 5, it must end in biopsy, because it is said you have to do a tissue to make sure that there is not a malignant thing hiding. I think you can have all this BIRADS category with you. You can copy it. BIRADS 0 says it is need for additional imaging. Sometimes patients do not want to have a mammography because they are afraid having a radiation dose, or maybe you can be sure that there is nothing malignant going on, and you do an additional ultrasound or you do an additional MRI. So this is at the BIRADS 0 classifications. And after you have done every image quality, you have to do a BIRADS which ends in a number, which is not 0. When you have a BIRADS 1, it is negative and it's a routine screening follow-up, and the malignancy is about 0%. Maybe it's not possible in medicine, but it's said to be benign. BIRADS 1 and 2 are benign lesions, so you have a routine follow-up. When you use the screening program, you do a follow-up in 2 years. But I will show you a few impressions of our screening program just in the end of my talk. What are you doing with a BIRADS 3? A BIRADS 3 is properly benign. This is said it is lower 2% of malignancy. Sometimes people are very afraid having a BIRADS 3, but I always keep telling them you have 98% which is benign, which is very much. And so you can convince them that they can go in the follow-up. But sometimes when they don't like to have a BIRADS 3, you have to do also a biopsy on a BIRADS 3, but this depends only on the patients. You do a short time follow-up. When you have calcifications, we do a follow-up in 6 months. It depends on the look of the calcifications. Maybe sometimes you do a follow-up in 12 months. When we do a BIRADS 3, we always do a checkup after 6 months, just to make the patient sure that she is not carrying a cancer with her. And we all should bear in mind that also men could have breast cancer. We find about 5,000 breast cancers a year in Austria, about 500 in the Tyrol, and about 5 to 10 male also have breast cancer. And this is very important, because you have to know it. Otherwise, they will die very early. BIRADS 4 is suspicious, so you have to do a tissue diagnosis. And we split the BIRADS 4 into BIRADS 4A, 4B, 4C, but it doesn't matter that really, because you have to do the biopsy, and sometimes you are right and sometimes you are not right. Most of the time when we say it's a BIRADS 4A, we say to the patient, you have a low suspicion malignancy of 2 to 10%, and we have to do the biopsy. And in a few cases, I find a cancer. In a BIRADS 4B, it's like you don't know it really. It's about 50% moderate malignancy risk, so you have to do the biopsy, and you say to the person, maybe the glass is half full, it is half empty. We have just to wait for the pathologists. And when we say the BIRADS 4C, it's a very suspicious lesion with a high malignancy up to 95%. So you have to talk to the patient that she is maybe carrying a cancer. And when we do a BIRADS 4C tissue diagnosis, and we don't agree with the pathologist, we normally discuss with the pathologist and do also additional MRI just to make sure that we hit the lesion. Because even if you do many biopsy, you hit the lesion not at the point where it's the most malignant part. So you have to be sure that you catched it. Otherwise, you have to do a rebiopsy to make sure that there is not a BIRADS 5 lesion behind. BIRADS 5 means that there is a cancer probability of 95%, which is quite high. And normally, when you do a BIRADS 5, it ends up in operation anyway. BIRADS 6 is proven cancer. It is important to know that you have a BIRADS 6 because when you do a chemotherapy, you have to do a ultrasound just to look at the lesion if their cancer is getting smaller. You saw these lesions. This is a fibroadenome. This is oval shaped. It's a bit lobulated. This is on a different machine. You see the hyperechoic rim, but it is look like benign. And there is no vascularization, and normally fibroadenomas are oval-shaped with nearly no lobules and no not much color Doppler inside. So you have to know that this is a fibroadenoma. But when you find the fibroadenoma the first time, it's always a BIRADS 3. It gets a BIRADS 2 when you know the fibroadenoma. This is a ultrasound BIRADS 3 because we find it new and is a bit hardened in the elastography. We do different parts of elastography. This is a strain elastography and this is a shear wave elastography, just to say what the lesion is like. But all of these lesions that you see here are biopsy proven. So normally when you see a lesion like this is a BIRADS 3, you do a follow-up because it looks like a fibroadenoma. But when the patient is older than 40, we normally put the needle in just to make sure that we don't miss a G3 cancer, because cancers which are quite not very nice look like fibroadenomas. So you have to be careful. This is a BIRADS 4A because you see the vascularization inside of the lesion. It comes from the outside, goes inside, have small cysts in there, and in the elastography it's quite smooth, quite hard, and this one was a papilloma, I think so, yeah. And these papillomas normally get removed in our department. Sometimes it is quite difficult because when we find a papilloma, we do an MRI and then we see several lesions that look like the same, and it's quite hard to do a good operation that it looks after the operation nice, because sometimes a papillomatosis is quite hard to remove. You have to discuss in the tumor board what you do, what's the best, but at least you have to look shorter on a papillomatosis, even in young patients. So, when you look at this picture, what do you think about it? Does it look nice?
I think it's interrupting the hoof ligament.
Yeah.
This should be bad.
Yeah. And there is some vascularization coming from the outside. The elastography is quite hard, and the tissue seems to be hard here in comparison to the nearby tissue. So I think Mariela is quite right. I think. What do you think, the audience? Is this a benign lesion? Is this a tumor? It's a BIRADS 4B in our classification, because it is not that ugly for me, but this lesion needs a biopsy, and we found a NSDG3, and this is what I tried to tell you before. Sometimes these lesions look not that bad and are really bad tumors. When you don't do a follow-up, even after 6 months, this lesion is double as big or 3 times as big as it was before. So you should put a needle in. And that's why we like this course, because we can show you how easy it is to put a needle in with ultrasound, and you don't do any harm because there is only a hematoma normally after the biopsy. When you use the biopsy system, as we show you in the afternoon, you will never hit the chest wall, so there can't be any severe problems. And you don't have to be afraid, and you should learn biopsy on breast lesions, and when you can do this really good, you can also do biopsy on lymph nodes, because this is a bit difficult. So, next. Also not very nice lesion. Why is this a BIRADS 4C? Because there is a hyperechoic rim around, and this is most of the time a good hint for a malignant lesion, because you can see the desmoplastic reaction around the tissue, and so this is not horizontal. This is vertical orientated and microlobulated, and with the hyperechoic rim it looks like a tumor, and this was also a tumor. But it doesn't matter. When you do a BIRADS 4 and when you do the biopsy, it doesn't matter if you say BIRADS 4C or 4B or 4A. It's only for the patient. And on Friday we say it's a BIRADS 4, and we don't say for A, B, C, because there is the weekend and the patients get mad when they know that this is cancer hiding, and then we say we have to wait for the histology. Sorry, and sometimes it's better to don't tell the truth, really. Yeah. So another BIRADS 5 lesion, 62-year-old patient with a new palpable lesion. This is a not very nice lesion because there are very many lobules in the lesion. This is also a stiff lesion in the elastography, so we did a biopsy, and this ends up in a tumor, which is the most common tumor, and is the NSDG2 in our department. We have most of the tumors in this classification. Another woman, this is quite hard to find out in ultrasound, because sometimes you can't say how big it is, because it is sometimes very, very big, because it's also stiff when you feel it, but sometimes they are old women, they don't come to screening program, and then you find a lobular cancer. This is normal. It is normal a palpable mass, quite hard to find out in ultrasound, quite hard to find out in mammography, because it's a hiding tumor. Yeah. And we do a mammography in each patient which is older than 40, because when they want to take part in the screening program, they can take part after 40. And then we do the decision between ACRA. This is a breast tissue, smaller 25%. We have a very high sensitivity of 98% and a very high diagnostic security. And this looks like this. You see fatty breast, there is nothing hiding. There can't be a tumor because there is a very nice view on the mammography. So mammography is quite worthy for not very dense breast, in my opinion. ACRB, breast tissue between 25 and 50%. Sensitivity is also quite high. And we can say in this tissue you see only image, you can see only less tissue, which is loosened. There is no tumor hiding. And this is quite easy to tell the woman, you don't have breast cancer, you are healthy, you don't need an ultrasound. They only get an ultrasound if they have a breast cancer history in the family or if they are very afraid. In ACR3, the sensitivity is going down to 70%. Most of the young women do have this type of breast tissue, so we are not that sure that the mammography is the best modality to find cancer. So it is, as in Austria, it is in this ACRC breast density, we do an additional ultrasound just to make sure that there is no small cancer hiding behind. We also do tomosynthesis, which brings up the cancer detection about 25 to 30% in dense breast, because you can see the architectural distortion much better than in a 2D view, but it's also possible to do a a 2D mammography just for screening. So ACRD, the sensitivity is going down. It's like a coin. You don't know if this is healthy or not, so you have a poor diagnostic security. But mammography is quite good for detection of calcifications, so there is a need to do a mammography, but there is not that good sensitivity, so you have to think about how often you do the mammography, even in young women. So you should do maybe the mammography every 2 years, like in screening program, but in dense breast you can do the ultrasound the year after. And when you see this picture, I can't tell if there is some small cancer hiding behind, because there is much breast tissue, less fat, and you see the limitations of mammography. In this breast, MRI would be much better, but MRI is quite expensive and not available everywhere. Maybe in a few years we do more contrast-enhanced mammographies, because then you can also have a better sensitivity for detecting small cancers. We use tomosynthese in screening because the sensitivity is going up, and the reduction of false negative is we found in our program, and the specificity is going up, also best for ACRC and ACRD breasts, because you can see the architectural distortion. What are we doing with ultrasound? The use of ultrasound, if necessary. Ultrasound is used in conjunction with mammography, even in ACRC and D, because the sensitivity of mammography is reduced. And ultrasound must be performed in any palpable lesion that the patient tells you. Even in KCRA, when the patient said she can feel something, we do an ultrasound because maybe it's behind the thickness of the mammography plate, so you can't see it on the mammography. So we do always an ultrasound when a patient have a palpable mass or when she says she has something that is suspicious. Yeah, this is also a breast density. Which density would you recommend for this breast? C, D? This is a D for in my...
Who said D? We had a good tradition.
That's good, that's very good.
Yes, who said D?
So you don't fall asleep? Who is for A? No. B? C? D? Nobody?
Not for D.
Oh, sorry.
Good.
Yeah. Another. Yeah. When you do the mammography, you should look at the technical standards because your technicians should bear in mind that the mammography is a radiative dose, so you should do proper images. That's why we have the perfect, good, moderate, inadequate classifications. And I will let Mariela this thing down. For the positioning, for the compression, for the exposure, the contrast must be within the rules, sharpness, noise reductions, artifact. You have to do the labeling on the breast side and the examination date. And the European guidelines says when a examination is done good. In newer programs, maybe for AI, they try to make a PGME system just which comes after the examinations. We tested a few AI systems, but at the moment we are not that sure that they are working that good. So we said to them they should do more work in progress. So you should look if the MLO positioning is present when the pectoral muscle is depicted in a correct angle within 1 centimeter for horizontal to the nipple. So you have to measure it. But I think you are all doctors in here, and this is for the technicians. But it is good when you know how an image should look like, then you can tell your technicians when the image is not in good quality. Because you can't detect any cancer when it is not on the picture. That's for all radiologists in this room. You have to talk to your technicians, and you have to do some working in progress when you find out that one person makes mistakes in the CC view all the time. You have to try to improve the image quality. In Austria, all of the doctors have to be radiologists, which are taking part in the screening program. We have to do a multidisciplinary course, and after this you have to do an exam, and then you have to send a case collection of about 1,700 mammographies a year, so that you can take part in the screening program in the next year. And this is quite good because when you don't see many mammographies, you don't have the experience to say what's going on. And when you find something suspicious, the person should go to the assessment center, and then you have to do biopsy or you have to do further images. But this is not for assessment centers are normally in hospitals. There is no assessment done in a clinical praxis, something like this. You should do the assessment as you should do the biopsy in hospitals. And then you should talk to the patients. They get the report with them. It is sent by post home, or they get the writing with them. And when you find BIRADS 4 and 5, it should end up in biopsy. Does anybody can see the tumor on this image? Pardon? Yes. Da kommt schon was. It's not that easy because it's quite dense breast, but the tumor is over here. And we did the ultrasound, and we find the tumor, and this is a really ugly tumor with hypervascularization, and you can see also the MRI, which is normal taking part in Austria for local staging, but you can also use a contrast mammography, which is much more cheap and also quite good for the quality. Yeah. And this is now for our cancer detection program. We are running the cancer detection program since 2014, so we have 10 years now cancer detection program. It is a very nice program, but it is free for all women within the program, and we do only have 50% who comes to the screening, and we can't believe it, but it is true. And maybe when we can't get the rate up to 70% or 60-70%, maybe we will use the screening program, because there is no sense doing a screening program, because the screening programs do work when you have a 75% of women who taking part of it, because then you can see the reduction of mortality in the for breast cancer. And our program is really nice because you get the invitation from the government. It's sent for all women after 45 every 2 years up to 74. And you can also take part when you just call the screening program when you just end 40, so you can take part at the age of 40 up as you want to. After 74, you can also take part. So it is really a nice it's a really nice program, but it doesn't work that good. So when you see in the report, there is a BIRADS 3. What means a BIRADS 3? BIRADS 3 means rescreen in 6 or 12 months, so that you can't let the cancer grow that much. What are you doing with a BIRADS 4 or 5? You have to do a tissue biopsy or in ultrasound, if it is possible. You should be able to do a domo biopsy or a stereotactic biopsy, and in an assessment center, which is quite big. Maybe you have also smaller centers, they can also do a MRI biopsy, but in Tyrol we are the only institution that do also all biopsy. We also do an MRI biopsy, but this is it takes nearly an hour to do an MRI biopsy, and it's very expensive, and it's harmful for the patients because it's in the tunnel and you put it out, you put it in, but you have to be able to do the biopsy when you are working in an assessment center. BIRADS 0 means you have to do a further imaging. And what are you doing with high-risk patients? We do not have only screening patients because we also have many high-risk patients, because we know something about the genes. And then we do a mammography and an ultrasound once a year, and in the other 6 months we do an MRI and the ultrasound. So you see the patient 2 times a year, and then they can do the decision maybe for operation when they are BCR positive, or maybe even if they are suffering with a different gene problem like Liefraumeni or something like this. There are many young people who have cancer history. Yeah. Stuff you should look at the family. You should ask if there is ovarian cancer in the family, if there are young women suffering with cancer. You should take a look. Maybe there is some BCR gene defect hiding. You should send them to was sagt man jetzt da? To the genetics, just to prove if they are carrying the gene or not. When you don't have the possibility to send them to the genetics, you should do a high-risk screening, at least 2 times ultrasound a year and once a mammography. Yeah, and on this image you can see also when you do a contrast-enhanced mammography. This is on this patient. In this case, the cancer is not that easy to detect. In the contrast-enhanced mammography, you can see the bilateral cancer, and this is also seen in MRI. So I think contrast-enhanced mammography is a worthy tool for local staging. It's more cheap and it's quite quick, and it's well tolerated in women because they don't have to lie in the machine. The examination takes about 10 minutes, and it's very good for bilateral and local staging. So, thank you for attention. This is me in my first meeting with Mariela, and I'm flying home with the brew, I think so. Do you have any questions?
If someone who has a question, the perfect will be if he stands here for this microphone, because, yeah, tell me. Okay, I got it. To turn it on. Yes, okay. Yeah. So if you stay here, then you will be on the picture. If you don't stay here, no picture. Okay. And no sound, yes.
And this is like our screening program is working if there are no questions. I can show you how the way of the patient is in the screening program, but when you want to ask me something, we can talk.
I have some questions.
Yes, please.
So you said the screening program in Austria starts at the age of 45,
Yeah.
but you also said that you start doing mammographies after the age of 40. How you decide, how it's happening for the age between 40 and 45?
Because we think that many cancers come in the age of 40, between 40 and 50. And in the screening program, the women have the possibility to take part in the screening program. They can just do a phone call and talk to the program. I would like to take part, and so they get the invitation after 2 years. So they can start at the age of 40.
So it's patient wish to
Yeah.
start early.
Yeah. And
Okay.
sometimes when a patient comes to our department and they do say, I have some pain, I have something, maybe I feel something, we start with mammography immediately at the age of 40, because it is better to start to have an image quality which is not only ultrasound, then you can be sure that you don't lose a cancer. Because we see quite a lot of young women suffering with cancer. Yeah.
And it's again every second year. Once you
Yeah.
start at the age of 40, then on 42
Two.
you have to go
Yeah.
again.
Yeah, you get the invitation at 42 again from the government. It's sent
Okay.
by a letter.
If it happens that you have a dense breast at the age of 40, do you stop doing mammography and do only ultrasound, or you do both?
We do normally both when they come, because it's the best thing to do the imaging. We do the mammography just that we don't miss any calcifications, and maybe in some decisions with very dense breast we do only tomosynthesis in one direction and we don't do the second view because we do the ultrasound in addition to this. Just to
One
make-
organizational comment. This is our next speaker, but I suggest we give her some time to relax and maybe even coffee, and then she she will join. Okay. I'm not sure. Over there, there are 2 chairs. If you want, you can take them. Okay. Okay. I want to ask again for the tomosynthesis. I think last time when I was in Innsbruck, you told me that you do one direction of mammography. You see, I remember.
Yeah.
And the other direction you do a tomosynthesis.
Yes.
This is like for screening for everybody.
Yeah, we do it for screening because it is said that it is possible to do it in screening. We do the tomosynthesis in our department in one direction and the other direction only in D2 technique because we think that it's more worthy because otherwise the dosage is coming up. Because tomosynthesis is a bit more dosage, so about 10% more. So I don't see the point to do it in both directions. But we have an argument in our program because some of our radiologists want to do the tomosynthesis in both directions, even in screening. I can't see the point, but you can't. It is possible to do it in screening because they have the instructions that they can do it. They don't get money for doing tomosynthesis in both directions, but they can. So a few of radiologists in Tyrol do the tomosynthesis in 2 directions, but I don't think that this is a good imaging for young or for women.
How many of people here have a tomosynthesis in their departments? 2, 3? Okay. Do you use them for, I don't know, just for screening? Maybe, yeah? How, Dr. Doneva, please, can you come? It will be complicated to come, but you should come and say how you do it in your department.
Only when we have indications for that, only when the breast is dense or some complications.
That's a good idea, but we do manage many people a day, so it's easier for our technologist when we do it all patients in the same procedure, because sometimes it is too much time taking making the decision in each patient. But this is a good way to do it.
The problem is not that medical, it's more because patient is not reimbursed from the government.
The government. So when we started doing tomosynthesis, it wasn't allowed to do it in screening program, but I just did it, and I didn't talk on the report that we made it. So because for me it was worthy to do the tomosynthesis because you can see more architectural distortion and more small cancers, and so I'm glad that they made the screening program with tomosynthesis now in this release.
And how many of you have, yeah, Dr. Donovan, you want to say something?
Can I have just one question?
But can you come here? I know.
It's short, slowly. Can you compare MRI and tomosynthesis apart from the availability? I mean, medical side of the when you choose MRI and tomosynthesis.
We use the tomosynthesis in normal screening. We use the MRI in high-risk patients or when we have to do further images. And when you don't have the possibility for MRI, maybe because of claustrophobia or something different for the patient, we use the contrast-enhanced mammography. And this is a quite nice tool to make sure that there is no cancer hiding. But the contrast-enhanced mammography has a few limitations, which are the you have a iodine contrast, and you have to be sure that there is no thyroid, no hyperthyroidation, and you have a normal renal function, and you have in elderly people you have to have a blood report. In young people we just ask if there is any problem. Yeah.
Okay. How many of you have MRI available? Okay, more people. What was very impressive for me in Innsbruck is that you have this register for BIRADS carriers, no BIRADS, for BRCA carriers. Yeah, so you actually know if someone is a carrier or not. Do you do intense screening also if you, do you test all patients with family history for breast cancer? This is first question.
Yes, we should test when they having a cancer family, but some women don't like to be tested, so we just do like high risk screening without having the cancer gene detected. But a few women don't want to know if they are carrying the defect gene, so you don't know it really. But we do have a register for the BCR positive people, and then we do the screening, like doing mammography after 40 and ultrasound, and in the other half of the year we do MRI and ultrasound. And we are thinking about when they get operated and they will reduce the risk. Maybe we do only a checkup once a year because they have normal risk.
Yeah.
Yeah. But this is not true at the moment. We don't know it. We are just discussing in the AGO, in the seniology. We are not sure what to do.
Okay, but if you don't have a proven BRCA, then you still do MRI once a year, or then, I mean, you use the same screening as for proven BRCA.
When they are young and do have cancer family, we do like for proven, because it is mostly likely that they do have a severe problem when there is a cancer family with sister, mother, aunt, cousin, which are very young. So we do the high-risk screening, because in Austria it's a bit easier. The government pays for the program.
Good.
For our screening.
Yeah. But you said that 50% screening coverage of the screening. You're not happy with this?
No, we are not happy. We're trying to improve, but we are going. Silke and I were in a shopping center promoting the program on 1st of October, but it was not that, I think so, worthy, because many people pass through. Nearly nobody comes to ask for something, and I think it doesn't really do that work. No. I don't know how to improve. Maybe we should change minds in young women. They take more care of their breast and of their health, but it takes a lot of time. Maybe we should go in schools and talk in schools to talk with young girls. Think about your family. Is there breast cancer? But there is no program at the moment to do it like this.
Do you think it's because women are afraid of radiation? That they don't participate in screening? Because I think sometimes in Bulgaria women are afraid of getting too much radiation.
I think some part is about being of radiation dosage. Another part is afraid of making the diagnosis, because when I found this very small cancer, a woman complained, "You make me ill," and then I looked like this and said, I can't help. I find the cancer and we should do something against it. But she was that out of order. We had to take the psychologist to talk to her.
Do you have a psychologist available? It's another issue that we need.
So because sometimes they don't want to know even when they know that they have cancer in the family, they don't want to take part in the screening program, and maybe because it's free, they don't like it. It's because they don't have to pay, and when you don't have to pay for something that it's not worthy, maybe this is a point why they don't take part in the screening program. When you compare Austria to Sweden or to Norway, we are right behind, and we don't get better in the last 10 years. We are just in about 50% of coverage. This is also in Switzerland is the same, and also in Germany. Maybe it's because it's free, we don't know.
But in the northern countries, is it still free?
Yeah,
Yes.
but the northern women are a bit different maybe, I don't know.
Yeah.
There are screening buses coming through the country, and you can just step in the screening bus, do your examination, and go home. Maybe this is a point. But Austria is not that big, and we have many screening possibilities just in the surrounding about 20 to 50 kilometers. So it's not that difficult to take part, but we don't know it really.
I have more questions. So, first, do you think this with the bus, because we also in Bulgaria have one society which is making this kind of a screening with a bus, but it should, how to say, the equipment there should be follow some criteria. And
Yeah.
do you think that these kind of machines that are mobile mammographic machines can meet the criteria for screening?
Yes, of course. Silke and I were in Chicago last year for RSNA, and we saw very nice screening buses which can do everything. They also are able to do contrast-enhanced mammography. This is really nice machines which is possible to take part in screening program. Yes, I think there is no machine which is not able to take part in screening on the market at the moment.
Okay.
All new machines do have the screening directions.
Okay. Okay, good.
Yeah, I think so.
It's good. Also, how many of you are doing biopsies? Is any of you doing breast biopsies? Yes, two only. Yeah, 4. Okay. I was. It's interesting for me what you say, because I have my pathologist here, Dr. Vlachova. So I very often discuss with her if I missed the lesion or I found the lesion. It's a very, and I beg her, please tell me I found the lesion. So another thing it's making me impression is that you do a picture or you do a short movie during the biopsy.
During the biopsy, we do always pictures. Sometimes we do a movie. Even for education, we do some movies. But we do at least a picture when you see the needle hitting the lesion in one direction, because we are quite doing many biopsies. But when we learn the biopsy to our assistant doctors, they have to do the needle position into directions, so that we can be sure that they hit the lesion. Yeah.
Okay, so it proves that you did your
Yeah.
job.
Yeah.
Dr. Vlachova, I'm also taking pictures of my biopsies. Okay. Okay, some more questions from the audience, maybe? Yeah. Over there.
Nice to see you again.
Hello.
I have a question. How many cores you consider that will be representative for lesion 1 centimeter, and how many biopsy cores for lesion 2 centimeters, taking in mind that there is some heterogeneity in the breast cancer?
We normally take 5 specimens of biopsy normally with 14 gauge. So our pathology says it's enough. When we think maybe we have a DCIS also in the lesion, we take a bit more biopsies, core biopsies. When we do a stereotactic biopsy, we take 12 at least in 10 gauge. And even when we do an MRI biopsy, we take about 12 small biopsies. With 12
Okay.
in an MRI biopsy. And in the tomobiopsy and in an ultrasound biopsy, we take 5 normal.
Do you have hematomas often?
We do have hematomas.
Yeah.
Sometimes they are quite big, even after vacuum-assisted biopsy, but then you have to wait until the hematomas go away, or maybe you can take the liquid out with a small needle.
Yeah.
Yeah.
Thank you.
We had a discussion, I think, last year about MRI after biopsy. How long time we should wait to have MRI after biopsy?
We do not wait normally after biopsy. When we wait when we have a very big hematome, then we have to wait. Even when you have hit a small lesion, maybe because you can't see it after hiding behind the hematoma. So then you have to wait about 2 to 4 weeks. That's quite sad, but sometimes it is necessary. But normally we don't have that much hematoma, so we do the MRI just after the biopsy. A week after biopsy, something like this. Because we have about 30 MRIs a week, and so we can just manage our patients.
You said 500 cases you have in your institution?
No,
year?
in
No?
the Tyrol we have 500 cases. We do have about 350 to 380 in our department.
And how many biopsies you do a year?
I think, I don't know it really, maybe 1,500? Maybe
1,500?
yeah, maybe 1,500 biopsy, because we also do have benign lesions. Yeah. Yeah. Yeah.
Do you biopsy lymph nodes?
Yes, we normally biopsy lymph nodes when they look like being affected with cancer. We do the lymph node biopsy with a 14 gauge histocore, and we try to take at least 3 probes, but most of the times it's possible to take 5 also. And we do a clip marker in the lymph node so that we can find the lymph node again.
Have you ever got complications after lymph node biopsy? Because I'm afraid I've done it 2 or 3 times, and every time it's something.
When I started in this department, this was in 2005. We only had a severe complications after lymph node biopsy. It was not done by me and not done by Silke, but this ends up in angio, because we have to stent the axillary artery. It was a severe bleeding, and this was the only complication we had. Since Silke and I were doing this lymph node biopsy, we don't have any severe complications, because we only do the biopsy when it is safe. Some lymph nodes you can't get because they are too near to the artery systems, or very thin patients, maybe it's not possible. And when it is quite a bit complicated, we do the lymph node biopsy in semi-automatic device, so it's easier. You go in the lymph node and you just close the needle, and you don't go forward, so you can't harm the patient. But lymph node biopsy are only done by Silke, me, and our staff, which is not by assistant doctors, because normally they are not that they can't do it properly, and maybe it's too risky. So we do the risky things, and we let the other do the normal things. Yeah.
Last topic. How is the training going in Austria to be able to do a breast biopsy and biopsy a lymph node? How many procedures you should be done? How it's going the education in this?
There is no numbers written down how many you have to do. In our department, our assistant doctors just has to learn how to do the ultrasound. They have to find a cancer, and then we start first for doing aspiration of a cyst, aspiration of a serum, and after they can do this, and they can do the both-handed procedure, so that they can see the tip of the gun. Then we start with a large tumor and going down to smaller tumors. And normally, all of our assistant doctors can learn it, because we do have many biopsies. We do have about, I think, 5 biopsies a day. So there are quite a lot of biopsies, and then they can learn it properly. But you should, yeah.
In your department,
Yeah.
you can do it.
Yeah, we try to learn it to each doctor in our department. Yeah, but I think this is not even in all hospitals in Austria that everybody is teach to do a biopsy, because when I'm doing the examinations for radiologists and I ask how many biopsies did you have done in your history, and some of them they don't do any biopsies, and this is a shame. Yeah, but in a university hospital you should learn it.
You said in your presentation that you should do a biopsy only in the hospitals in Austria, because
Yeah.
I do it in a hospital, but it's not obligatory. I can do it in the ambulatory, wherever.
In Austria, there is when the assessment comes out of the screening, it is mandatory that you do the assessment in a assessment center. I am not sure when the assessment is done in a private practice, what is going on afterwards, because you have to make sure that the patient gets the report, that you have to reassure that the patient knows what is going on in her breast, and this is not in private practice normally. I'm not sure if it is allowed. We are just discussing, because one of our colleagues want to start biopsy in private practice. He didn't start at the moment, but we have to think about if it is allowed to do biopsies in private practice. But maybe it is allowed, but the government will not pay for it. So the patients have to pay for the biopsy when it is done in private practice. Yeah.
I think you can do the biopsy and the practice. That is no problem it's no problem for the procedure to do it in the private practice. But if you tell the patient that it is cancer in a private practice, you have to send her to hospital. We have a procedure we bring there on our own to the gynecologist or to the clinical partners, and that is much better for the patient than waiting 2 or 3 days and going to the hospital on their own, I think.
Yeah.
Okay, and very last, how many mammographies you should see a year to participate in a screening program?
1,700 mammographies for each, and we have the double reading system, so it is twice. We have about 12,000, so it's no problem for our department, but when you have only less than 1,700, you can also go to a special course to get more numbers.
Maybe can you tell about the course that you're organizing in Innsbruck? But it's in German, right?
It is in German. We do an ultrasound course This is the second ultrasound course. We do it in November, and it's about also biopsy and decision between benign and malignant lesions, and it is for all interdisciplinary, because it's not only for radiologists and even for gynecologists or surgeons or private practice. They can also get the certifications that they can do a breast ultrasound. And after this course, you get some sticker or some certifications, and you can use the insurance company to pay for these examinations in private practice. So this is quite nice. Yeah.
Is it open for international participation?
Yes, it is.
Okay. It's in German. Yes, it's in German.